In this lesson, we will explore the indications and goals of surgery to treat endometriosis in the adolescent. Only small studies providing low-quality evidence are available in the literature concerning surgical treatment of endometriosis in adolescents. The management of endometriosis in adolescents is similar to its management in adults, with emphasis on optimizing their long-term health, reproductive, and sexual function. In adolescents with endometriosis, clinicians may consider surgical removal of endometriosis lesions to manage endometriosis-related symptoms, especially when medical treatment is ineffective, contraindicated, or poorly tolerated. Diagnostic laparoscopy may also be offered to adolescents whose symptoms are highly suggestive for endometriosis, but imaging techniques are negative and symptoms are unresponsive to first-line medical treatment. After surgery, 80% of patients report an improvement of painful symptoms. However, symptoms recurrence rates may be considerable, especially when surgery is not followed by hormonal treatment. Also, patients' age at first surgery likely correlates with the number of overall interventions a woman may endure during her reproductive lifetime, so recurrence is of significant concern in this population. Symptoms relief after surgery has been described by different authors, especially dysmenorrhea, dyschezia, constipation, tender examination, painful exercise, intestinal cramping, and bladder pain. According to other studies, clinical recurrence rates, defined as endometriosis-related symptoms or ultrasound diagnosis of ovarian or pelvic endometriosis after initial surgery, amounted to up to 56% of adolescents after a follow-up of at least 5 years. However, no specific risk factors for recurrence have been identified yet. The international guidelines recommends that if surgical treatment is indicated in adolescents with endometriosis, it should be performed by laparoscopy by an experienced surgeon, and, if possible, complete laparoscopic removal of present endometriosis should be performed. Excision of endometriosis seems to yield better outcomes in terms of dysmenorrhea, dyschezia, and chronic pelvic pain compared to ablation of lesions. Nonetheless, in a decision to proceed to surgery, the risks of surgery and postoperative complications and considerable recurrence rates should be considered against the relative benefit of surgical treatment. There is currently no consensus as to whether surgery should be avoided as much as possible in teen patients, or surgical treatment should be considered at an early stage and should aim to eliminate endometriosis completely, including deep infiltrating endometriosis. In fact, there is no evidence that surgical intervention for endometriosis in the adolescent impedes disease progression or long-term consequences such as infertility. Moreover, hormonal treatment seems crucial after surgery in order to prevent or reduce the risk of recurrence and progression of the disease and the recurrence of symptoms. Therefore, postoperative medical therapy is recommended in line with management in adults.